So, in keeping with the sleep apnea theme, I just wanted to do a short video on some of the things that we look for or look at when patients come in. Um, and these are kind of risk factors, I guess, for sleep apnea. Just because you have one of them doesn't necessarily mean you have a problem. It just is the more that you have, the more likely you are to have a potential issue. So, first and foremost, as with a lot of things, and pretty much everything, is familial history. So there's a genetic component to just about everything, and there is a genetic component to sleep apnea. Um, I had said in another video that we used to think that sleep apnea was just due to gains in weight and getting older, and those things do affect sleep apnea, but they're not necessarily. It's not just necessarily old fat guys, like I said in a previous video. I have sent patients to be tested, thin younger women who have had sleep apnea. So it depends. But one of the things about family history is that if, like, for example, one of your parents was diagnosed with sleep apnea, um, there's a pretty strong chance that as you get older, you're going to be at risk if you're not already at risk now. The other thing is that, and this is just like the family history of anything. If you have a family history of periodontal disease, for example, you have those genes. So sleep apnea has to do with a narrowing of the airway space. So people who have longer necks, I have a longer neck, for example, are actually more susceptible to airway problems. And there's other factors, but it is a physiologic issue when air does not get down the airway. It has to do with the size of the airway, and the size of the airway, as I said, can be hindered by excess weight, but it doesn't necessarily have to be just in larger necked people. Um, Another thing that we ask for on our the things we screen for, we always ask about snoring. And as I said before, snoring is not necessarily a doesn't necessarily mean you have sleep apnea, but it definitely is a risk. It definitely means that there are noises taking place in the back of the throat because air is not passing silently through there. So snoring is something that should be addressed from the standpoint of how loud is it, how often is it occurring, and the other thing to keep in mind about snoring is that you don't know if you snore. You have to be told by someone that you snore. The only exception for that is if there are times when I've had patients who have had, we call it an arousal, but it's basically you get woken up because you wake yourself up from snoring. And it's not actually, you're not waking yourself up from snoring, you're actually waking yourself up from not breathing. And so, and that happens. It happens more often than not. So, other things quickly, history of daytime drowsiness. If you are fatigued, say like 2 o'clock in the afternoon all the time, you're not sleeping well. You're not sleeping well. So, history of clenching and grinding. The reason that clenching and grinding has to do potentially with sleep-related breathing issues is because a lot of times the body does things with the jaw to try to open the airway, and doing something with the jaw back and forth is commonly seen in people who have sleep breathing disorders because the jaw is trying to move forward to keep the airway open. History of a TMJ disorder is another one. History of mood disorders and depression. A lot of those, that's on there. Retrognathia. So retrognathia is people whose jaws are further back than their upper jaws. So when the jaw is further back, the tongue tends to be further back, which can impact the airway. Witnessed apnea events. So this is, again, this is someone who is sleeping at night and whose bed partner says that they hear them pausing and then breathing again. And that's a common thing to hear. Another thing we look for is we look at the tongue. Physicians like anesthesiologists use what's called a Mallampati score, which is how much of the back of the throat they can see when a person opens like this. So sometimes in some people the tongue sits above the level of the teeth. In other people it sits below the level of the teeth. In some people, they'll open the mouth and all you can see is the tongue. That would be a Mallampati score of like 4, which means that you can't see anything. And then the scalloping of the tongue is also something that we see a lot in dentistry. And scalloping is the sides of the tongue are actually scalloped as opposed to smooth. And that scalloping is the tongue pressing up against the sides of the teeth, putting the indentation of your teeth in your tongue. And that is typically thought of from the tongue trying to get the heck out of the way to open the airway up. So tooth wear, especially front tooth wear, when the jaw is doing those movements to try to get the airway open, teeth wear. So hypertension, they say, I've heard in my courses that I've taken, that if you're on 2 or I think it's 3 blood pressure medications, you get, for whatever reason it is, you should be screened for sleep apnea. Gastric reflux, commonly seen in people with sleep apnea. Neck size, we do look at neck size. A larger neck has more of a chance of people having sleep breathing related issues. But those are the types of things that we look for in our dental patients. And we also give something that's called an Epworth Sleepiness Scale test, which is basically one of those things I said about history of daytime drowsiness, that kind of is a objective way to measure sleepiness. And then I also have a sleep screening form that asks other questions about sleep. But I would suggest that if you do have issues with sleep, any issues, that you discuss them with your dentist. Your dentist might know more about sleep than you think. So until next time.